Hello everyone, this is Cha or Halo speaking on behalf of UPMed Class 90 and Class 93 webinar teams. The UPMed webinar series is an initiative of the University of the Philippines Medical Alumni Society. It delves on important, current, and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health MDs, primary care physicians, family and community medicine physicians, and other health workers. Registration is free and we are now using GoToWebinar. If you're encountering problems as you participate, please log out from the session and rejoin again. You may use the join link sent earlier to your emails, or you can enter the webinar ID 386121579 in the page indicated on the slide or in the GoToWebinar phone app. Due to erratic internet connectivity depending on your area, you may get disconnected during the webinar. If this happens, please restart your session. If you cannot rejoin the meeting room, kindly stream the session at livestream.upm.edu.ph or watch the Facebook Live video on our page. Before we start, here are a few reminders. Your mics are muted throughout the meeting. Use the questions box mainly for your questions or comments. The question and answer portion will be held after the lecture and will be facilitated by our moderator, Dr. Noel Carino. The webinar will run for an hour with 30 minutes allotted for lecture, followed by reaction and a question and answer portion. An evaluation sheet will be sent to your emails after the webinar. Please answer it to receive your certificate. We will now call on Dr. Carino.
Our time now in Manila is 12:01 as I am speaking from the IMS building in UP Manila, Padre Faros Street, Manila. Today's topic is vision screening, guidelines, and strategies. Today's learning objectives are as follows: to define vision screening and comprehensive eye examination, to identify children with visual impairment or eye conditions that can be picked up by screening, to outline the tools used in vision screening, plan a cost-effective method of performing vision screening in the community. Today's speaker is Dr. Albina Pauline Santiago. Dr. Santiago is a graduate of the UP College of Medicine Class 1990, completed her residency in ophthalmology at the UPPGH. Dr. Santiago also completed a fellowship in pediatric ophthalmology and adult strabismus at the Children's Eye Center of New Jersey, and another fellowship in pediatric ophthalmology and strabismus at the Jules Stein Eye Institute at the University of California, Los Angeles. At present, Dr. Santiago is a clinical associate professor at the UP College of Medicine and a university researcher too at the Philippine Eye Research Institute. Dr. Santiago also works as section chief of pediatric ophthalmology at all the hospitals now, at PGH, the Medical City, Manila Doctors, and St. Luke's Medical Center, Quezon City. May we now call on Dr. Santiago.
Okay. Thank you, Dr. Carino. Good day or good evening, everyone. This is Dr. Pauline Santiago. I was tasked to discuss vision screening strategies and guidelines. These are my disclosures. I am Clinical Associate Professor at the UP College of Medicine, where we teach at the Centro Oftalmológico Jose Rizal. I am staff of Medical City, St. Luke's QC, Manila Doctors, and I'm a researcher also for the Philippine Eye Research Institute. I have no direct financial interests with any of the equipments or toolkits mentioned. The objectives were were enumerated by Dr. Carino, so let's just go ahead and go to our first objective, which is to define vision screening and comprehensive eye examination. Vision screening is not the same as comprehensive eye examination. Sometimes some patients pa nga will include newborn screening, so that's a all different topic altogether. No? So vision screening is not an eye examination. An ophthalmologic exam or the comprehensive eye exam performed by the ophthalmologist involves several components. No? There is some type of vision assessment, evaluation of the pupils, to check the eye and the ocular agnexa. You check the eye for gross abnormalities. The IMD also performs refraction, an extraocular muscle evaluation or a sensory motor evaluation. If magnification is needed, it's done using a slit lamp or biomicroscope, as depicted here. The posterior pole is visualized looking at the retina, optic nerve, and our retinal vessels. Okay. In contrast, vision screening actually really is only one component, vision assessment. But if you look at the literature, there will be some groups, however, that will insist on what I would like to call vision screening plus. And this is a slide that includes vision screening plus for the non-IMD. The non-ophthalmologist can, for example, also check for pupil reaction and abnormalities. Can do a gross evaluation, a comparison of the red reflex, an extraocular muscle assessment by the simple alternate cover test, where one also refers anyone detected with eye refixation movement. For the IMD, who is not a pediatric ophthalmologist, you can add refraction, color testing, and some type of binocular vision testing. This is an old slide by Dr. Rondaris, which she showed in 2013. The highlighted column is that for a pediatrician who can do all the things ticked here if he or she were to do a comprehensive eye examination. Compared to the ophthalmologist, the eye exam is short of a slit lamp evaluation, which can actually be replaced by evaluation using any type of magnification. The pediatrician is not expected to do retinoscopy for refraction or the prism cover test. The columns under vision screening, which I think should really be called vision screening plus, lists history, corneal light reflex, external eye exam, visual acuity measurement, alternate cover test, and evaluation of the extraocular muscles using ductions and versions. You can imagine how long the screening will take and how resistant barangay health workers, teachers, and even school nurses were when this was being discussed. So this is why rapid screening for an eye anomaly or pathology can be simplified to just visual acuity assessment. Okay. Next objective is identifying children with visual impairment or eye conditions that can be picked up by screening. In 1999, the World Health Organization and the IAPB, or the International Agency for the Prevention of Blindness, came out with a Vision 2020 report for the right to sight. In that document, they stated that 1.4 million children are blind, 1 million of whom are in Asia, which includes the Philippines. While the prevalence is low, estimated only at 0.3 to 1.5 per 1,000 population, the lifetime ahead of a blind child translates to 75 million blind years. If you count Asia alone, if the life expectancy is around 75. The sad part here is 40% of the 1 to 1.4 million blind can actually be prevented or treated. Vision 2020 aimed to eliminate blindness by the year 2020. That's just 2 years away. The interventions aim to prevent projected doubling of avoidable visual impairment from 1990 to 2020. The graph on your right shows that a little over 10 million children aged 5 to 15 years have only uncorrected refractive errors that can be addressed. Okay, this is a complete list of the causes of avoidable childhood blindness from Vision 2020. No child, however, should be blind from a refractive error, and yet it is on this list. In 2003, the American Association for Pediatric Ophthalmology and Strabismus published uniform guidelines for reporting amblyogenic factors detected by preschool vision screening. This was so sensitivity and specificity values can be comparable across studies. Essentially, the factors that should be detected by preschool vision screening should be evaluated using its ability to detect significant refractive errors, strabismus, media opacity, ptosis, and poor vision from other reasons. As automated screening slowly encroached into the practice of vision screening, the same group published guidelines for automated vision screening, Again, these tools target refractive errors that have risks for developing amblyopia, manifest strabismus, and media opacities. So target diseases for vision screening in many studies include refractive errors, which has a prevalence of a little over 20%. Amblyopia occurs in a smaller group, ranging between 0.74 to 6%. Strabismus prevalence is between 2 to 4%, and media opacities, although with devastating effects on vision, occur only in less than 1% of the population studied. So let's define some of our problems picked up by screening. So what are refractive errors or error of refraction? Turn your attention to the eyeball labeled normal vision. Notice how parallel light rays are made to converge or focus by the lens to end on the retina or the macula. That is your normal vision. To simplify the discussion, the eyeball that is myopic is longer than normal, so that those light rays focus in front of the retina. And your farsighted patient or your hyperopic patient has a smaller eyeball, so that the light rays focus behind the retina. And what is astigmatism? Just to simplify the discussion, simply means instead of being shaped like a sphere like this ball, your eye is shaped more like the American football. Amblyopia is a reduction in vision that occurs when the brain does not get the normal stimulation from the eye. This can occur in one or both eyes and occurs only in the immature visual system. If not treated in childhood, the loss of vision can be permanent. Untreated childhood amblyopia remains to be the most common cause of vision loss in adults aged 20 to 70. And amblyopia is most commonly caused by untreated refractive errors, strabismus, or defects in the eye, such as cataract. This is a slide series of what eye misalignment or strabismus is for purposes of those who are not in the ophthalmology field. This is sorry, how do I go back to my other slide? My slide, I think, okay. This slide is a patient with an outward deviation or a left exotropia. This is a patient with an inward deviation or an esotropia. This is a patient with an upward deviation of the right eye or a right hypertropia. And this is a patient with a combination of ptosis and an outward deviation of the left eye. Common media opacities can be seen in cataract and a leukocoria from retinoblastoma or ocular tumor. That ends our discussion on the types of visual impairment picked up by screening. So we now go to the tools that we can use, like animate pa siya. Okay, outline the tools that we can use in vision screening. Okay, visual acuity screening remains to be the current gold standard when you want to do vision screening, unless the child cannot reliably perform such a test. The picture in the previous slide, I forgot to mention, is actually also a tool for vision screening. If you remember your ophthalmology rotation for the doctors or nurses who are here with us, vision that improves with pinhole implies that there is a refractive error that can be improved by giving glasses. These are some of the tools that you can use for children less than 6 years old. Leia symbols and HOTV is a chart. This one is a camera. This one are your instrumentations. This is a computer program. Okay, let's see. Let's go through that. Okay, this is the famous Philippine Eye Research Vision Screening Kit. Leia symbols are utilized in the Peri Vision Screening Kit depending on your center or your child's age. This uses a pass or fail system where a child is asked to identify at least 50% +1. So in this case, it's 3 out of 5 optotypes in the line. Above the red line is 2040, below the red line is 2030. You can also opt to use the number chart that way. No? Perry has modified the chart to include pass or fail system also, or critical line testing also, for those who would like to use the number chart. This one uses 2030 line because this is used for the older child. This is the HOTV chart. Some charts use the letters HOTEX. It can be played as a matching game. The patient can hold up the letters corresponding to the letters that you point. And then you can also modify this so that you also can use critical line testing. Just show a 2040 line or a 2030 line and see if the patient can see that line. And then these are your common photo screeners and autorefractors. Here are some that you will see in the market today. The local Welch Allyn distributor is very aggressive in marketing the Welch Allyn spot screener, and you will probably get this if you're a pediatrician. You'll probably get them marketing this to you. Digital photo screeners use the asymmetry of the red-orange reflex and the crescents that form in patients with refractive error. In the picture on the left, the bottom two pictures represent normal. You see how the red-orange reflex fills up the pupil almost equally. No? This is a patient with high myopia. You see a crescent on top. This is a patient with hyperopia. You see the crescent below. Here is another type of digital photo screening. The crescents here with an asymmetry of the crescents with slightly bigger crescent here. There's asymmetry of the red-orange reflex, and there's a yellow reflex here and a crescent here. So those are the cases that you probably need to refer for an ophthalmological exam. The first generation photo screener, it's black and white. The child here has hyperopia or farsightedness, and indicated here with a white crescent in this black and white photo. The sensitivity and specificity ranges. Sensitivity is 65% and specificity was only at 87%. These are your newer instruments. This is your Retinomax. It has the capability of being used as an autorefractor, and the Retinomax Plus even has a keratometry readings. This is the Welch Allyn spot screener that can be used for refractive errors between plus or minus 7. I had the opportunity to use this machine as a demo unit in the clinic and have not been pleased with the results. I had a lot of false positives, but I guess it's okay to err on getting false positives if you're going to refer patients for a complete eye exam. Perhaps its utility is not in the ophthalmologist clinic, but none of the screeners. Let's see, this is a printout of the Welch Allyn spot screener. You see there's a refractive error here. There is your PD here. There's your Hirschberg's light reflex. This is the degree of displacement. So that's indirectly your gaze and your prism problems. So this eye, the spot screener correctly detected that the eye requires an eye exam because of the myopia here or the astigmatism in both eyes. That is your spot screener. Okay, the referral threshold for the Welch Allyn spot screener for our age group, probably this. Okay. Then a group in, I think this is Storm Eye Institute, that studied the sensitivity and specificity in the patients we want to study, patients more than 48 months. Sensitivity can be as high as 89.6, but specificity, while initially low, At 56.7 in the younger age group, it can go as high as 80.3% if your child is more than age 4. This is the iSpy 2020. It's based on it's a computer software where you can put unlimited installations of your software within each licensed school. They charge you based on the number of students in the school. I don't know if we will have this here soon. It contains programs for visual acuity testing, depth perception, color vision, and even boasts of a data management system that is HIPAA compliant, protects your privacy. This is a sample printout. This is the generated report from iSpy. With cloud-based storage, iSpy 2020 can integrate and store data from all other devices such as photo screeners and even school databases. Okay. For the older child, it's going to be a little bit easier. You can use your Sloan chart, HOTV chart, and Leah numbers. Some will probably still use the Snellen chart, so I just put it there. But I want to remind you that it is actually considered outdated. Now, why is it outdated? Your Snellen chart, how many of you still memorizes DEF, POTEC as the minimum required so that you will get your driver's license? No? It's outdated because of the extra serif or the extra figures here. This is the preferred chart because of the simplicity of the font type. This is an HOTV chart with crowding bars to simulate crowding phenomenon in patients with amblyopia. This is your, I showed this because of the Leah numbers chart here. This is how we initially started. We gave a critical, this is a threshold chart, but we decided to shift it to a critical line testing. So that it's just going to be a pass or fail to make the administration faster. Some tools that you can use, Penlight, you can use to check for pupillary reaction. You can use any form of cover to test for movement under the cover using the alternate cover test. You test your ocular muscle movements using ductions and versions. You test for binocular function using a random dot stereogram like this one. And your color vision test, you can use your Ishihara. You're supposed to see a number here. If you don't see the number, is it a 3 or an 8? If you don't see that number, I think it's a 3. If you don't see the number 3, then you probably have some type of color deficiency. Okay. The stereo acuity chart, the old Titmus fly, was also studied. You need a 20/25 visual acuity to see 40 seconds apart. This is the 9 circles this chart is talking about. So if you can see, you can discern the difference here. Both your eyes should have at least 20/25. No? So if your vision is 2200, for example, you're only expected to perform well in the first plate. So we sometimes use this for malingerers who will tell you there's something wrong with the vision, but can ace this test, so you know that the vision in both eyes should at least be 20/25. This is Bruckner testing. This can be used to demonstrate the asymmetry in the red-orange reflex. Your cameras, your cell phones can be used as screening tools to see the red-orange reflex asymmetry. We get a lot of these referrals. This is a patient who the patient's parents think the child is cross-eyed. I point them to the Hirschberg's corneal light reflex. You see them centered. I draw the circle and put the star in the center. They still don't get it. Sometimes this one gets them. You draw a sclera for them and you center the pupil and you see that the corneal light reflex is centered. Now sometimes I've had to use a picture of another chart. Somehow if you show them the picture of another child, parents become more objective and then they suddenly understand that oo nga, my child is not blind and is only pango. Okay, or with a flat nose bridge. This is a true esotropia. This is a patient with a centered corneal light reflex here, and you see the reflex here that's temporarily displaced. Now, this is a child with a right esotropia. This is the alternate cover test that was talked about earlier. You see movement. When you move the cover, then you refer that patient for evaluation. If you extend it a little bit for the ophthalmologist or the eye care professional, your alternate cover test can be also expanded to be an alternate prism cover test. So you put the correcting prisms until you no longer see movement in the eye. Okay, that's your alternate prism cover test. Okay, that's courtesy of Dr. Ruth Peña, so that's not me who made this one. Okay, now for the last one. How do you plan a cost-efficient method of performing vision screening in a community? Okay. For mass vision screening, you have to talk about cost efficiency. It should be quick to perform. So I would rather recommend critical line testing, where it is a pass or fail system. It's probably faster than using threshold acuity. Photo screeners can be used if the child cannot read, or your critical line testing, or you're testing younger children who will not cooperate for your critical line testing. But remember that photo screeners do not actually give you a visual acuity, but really just gives you the risk factors for amblyopia. They pick up the risk factors, the high refractive errors that may lead to amblyopia. So you'll have to settle on the sensitivity and specificity issues of your screeners. Then what we found out in some of the communities that we've tested, you actually have to include provision for intervention and giving of eyeglasses. Pag hindi, they stop going to you. Parang if they don't get anything from it, parang they are not encouraged to go see you. Now in the Philippines, we got lucky. You get legislation on your side. Republic Act 10157 established that children will now enter the public school system at age 5 years. This is the act institutionalizing kindergarten education to the basic education of the Philippines. No? And then what else did you do? I think this is Philippine Eye Research Institute worked closely with the Senate and the House of Representatives trying to get a bill passed that establishes a national screening program for kindergarten pupils. Leo can probably update us later about the status of that. Are the bills, if you want to remember the numbers. Okay. Okay. In the absence of a national policy, which is the state that we are in now, we can actually coordinate with local eye health experts. You can contact the LGUs or local government units to assess your local needs and develop a local plan. This can be implemented even before our national policy is put in place. Now, when do you screen? The timing of vision screening, it's judged that age 4 to 5 is actually the best time. It is cost efficient. It is most beneficial. Your children are more cooperative for your test. The younger they are, you will get a lot of false positives because they cannot complete your tasks. The age 4 to 5, the children are more cooperative. If they're older, 6 to 7, they might cooperate more with your tests, but they will have poorer outcomes for intervention. So that's age 4 to 5. So then after doing your school entry vision screening, then consider doing an annual eye exam. So that is in keeping with the vision screening guidelines that we published. Vision screening for amblyopia and strabismus is recommended for all children at least once using an age-appropriate chart. So what do we mean by an age-appropriate chart? You can use Leia symbols for the younger age group. You can use Leia numbers for the older people. You can use your HOTV for those who will just want to do the matching game and will not talk to you. And then, of course, for the cooperative child, you can also use your Snellen acuity test. This is a sample of a threshold acuity test chart. Sometimes you will see different notations, but you really just want to know what 2030 is in different notations or what 2040 is. If you're using a 4-meter ETDRS chart, that's 4/8 or 4/6.3. If you're using Logmar, that's 0.2 or 0.3. Okay, there are some that will use letter count, so that's 90 letters or 85 letters. This is an actual side-to-side comparison of threshold acuity. This is threshold acuity in using Lea symbols, and this is a critical line acuity, which I've shown you earlier. Okay, this is the one we use in Perry. For the 4 years old or older, we use the 2030 line. The critical line is pegged at 2030. For the younger child, this is the 2040 line. Okay, Vision 2020 also suggests promoting school eye health programs, especially for the common condition of error of refraction. If prevalence is more than 2%, if you have a high prevalence in your locality, ensure that the children undergo a simple vision screening examination. And finally, I think Dr. Cobillan will attest to this. We have to do this. Provision of spectacles may also have to be incorporated in the program. Okay, my suggestion to school health physicians, LGUs, or regional health units, regular vision screening does not have to be complicated. Consider critical line vision screening, where you just need to read a line and pass or fail that line. And maybe you can do this annually. That should have actually ended my slide, but let me just go ahead and mention a little bit of what adult vision screening entails. No? You get some type of visual acuity testing during driving tests. You have pre-employment screening for a lot of job applications. You have color deficiency screening, used for optic nerve head evaluations, and diabetic retinopathy screening by any means, like your indirect fundus photographs and wide field imaging. Your optic nerve functional assessment can be as simple as using the red color plate here. You just compare the red color in the right and the left eye, and a eye with an optic nerve dysfunction will report some type of desaturation. Then we've shown you this Ishihara plate for color vision testing. Now for diabetic retinopathy screening, there are a lot of tools we can use. We can use direct ophthalmoscopy, but we also use fundus photograph. This is regular fundus photo. This is a wide field fundus photo. The smallness of the image here is compensated by the fact that the machine can allow you to magnify images and you see more in the periphery. This is a sample of an OCT of normal retina and an OCT of retina with cystic spaces like in your macular edema. Okay, then of course, cataract screening, you can use your pen light, you can use your slit lamp, which is more ideal so that you can assess how bad your cataract really is. Then for glaucoma screening, we use fundus photography, we use visual fields. This is a tonometer measuring the pressure, and this is your OCT of your optic nerves, and I think this is a macula OCT. Okay. I think that's my last slide. I will end my slide with a quote saying, "The world through the eyes of a child is the purest joy that anyone can experience."
Thank you, Dr. Santiago. As expected, it's a very comprehensive lecture, as comprehensive as her notes, which we were copying during med school. We now have 318 logged to the GoToWebinar and 40 through the UP live streaming and Facebook Live. We'd like to thank Manila Doctors Hospital for sponsoring today's webinar. Before we proceed to the question and answer, we'd like to introduce today's reactor, Dr. Leo Cobillan. Dr. Cobillan is a graduate of the UP College of Medicine, Class 91. He did his residency in ophthalmology and fellowship in external diseases at UPPGH. He then completed his fellowship in cornea, uveitis, and external diseases at the Francis I. Proctor Foundation, University of California, San Francisco. Also earned his Master's in Public Health at the University of the California School of Public Health. At present, Dr. Cobillan is the director of the Philippine Eye Research Institute, which we shortcut as PERI, and president of the Santa Lucia International Eye Bank of Manila.
Thank you, Dr. Carino. And yeah, it was indeed a comprehensive lecture by Dr. Pauline Santiago. At least now we don't have to copy the notes. And let me take off from these points on vision screening, which Dr. Pauline presented, that the target diseases for vision screening would include refractive errors and amblyopia, which comprise majority of what we see among children. And then the most common visual loss among adults 20 to 70 years of age would be untreated childhood amblyopia. And if these are not treated in children, it leads to permanent visual loss. And of course, she presented several options and methods for vision screening in children. And in particular, we want to focus on on what can be used for mass vision screening, which has to be cost effective and quick to perform. Now, vision screening for a population is quite challenging, especially in a country like the Philippines, because it has to be simple. It has to be something that that can easily be implemented in schools. It is difficult because, like in a school, there was one school we visited. They have 1,200 students per grade level, and they only have one nurse for that entire school. And taking from the statistics worldwide, if we extrapolate it for the Philippines, 4 out of 40 pupils. In the Philippines, we have 40 children in one classroom, and 4 out of 40 pupils would have visual problem, and 3 of which would be error of refraction, and 1 would be amblyopia or other conditions. And if you look at the number of schools we have in the country, we have around 40,000 primary schools in the country, and we have around 2 million kindergarten enrollees every year. So with this, we are looking into how we could, there are, in most countries, there's no need for a policy legislation for vision screening because it's part of the regular healthcare delivery system in most countries. But in few countries, we need, like in the Philippines, to have a policy so we can implement this as a mass screening nationwide. And there are several components that we look at. If we work on a policy, we look at evidence-based researches, the recommendation, then we go into legislation, partnership, and implementation. And this usually takes around 3 to 5 years. We look into the evidence-based research for vision screening. We look at the burden of evidence. So since we have around 10%, 4 out of 40 pupils have visual problem. So we can do a mass screening for this. And the test accuracy of the chart that we have is quite good. And the availability of treatment as well. In the majority of cases where there's amblyopia, due to an isometropic amblyopia, the treatment will involve patching one of the treatment for that, and which is cost effective. And we also look at the recommendation of others as well as the experts. So Dr. Pauline mentioned that the best time to screen would be 4 to 5 years of age. In some publications, they have 3 to 4. But in the Philippines, from 3 to 4 years old, we don't see them in our healthcare system, not much. That's past beyond the immunization period, and they are not yet in school. So the recommendation would be the vision screening at school entry. Previously, before the K-12 system, the children in the Philippines would go to school grade 1, 7 years of age. So that would be too late to screen and intervene for a possible amblyopia. But with the K to 12 system, which was done through a Republic Act and has been implemented over the past few years, the kindergarten pupils are 5 years of age. We're able to identify and treat amblyopic children before the age of 7. So Dr. Pauline showed this. No? So this is the kit that the Philippine Eye Research Institute worked on to utilizing one of the charts recommended, which is the Leia symbol chart, and it comes with the transparent key so that it's easy to which object the student is pointing at, and of course the occluders and the standardized distance from the student to the blackboard. And this as mentioned earlier, we use the critical line screening, where it's a pass-fail system, and since and for students who are 3, 4, or 5 years old, we use this level above the red line, and the 2040 line, and then 2030 for 6 years above. So as mentioned, they pass if they are able to identify 3 out of 5. And so with this, we went ahead with the legislation, and we started 2016, the 16th Congress. We're able to reach 3 readings in the House Bill 6441, and in the Senate, it was just 2 readings, so it was not passed. No, so we move on to the 17th Congress, and it was passed in the House, and it was just adopted. So it was easier this time. It was adopted by the Senate recently. That's February 2018, and so we're hoping that it will be passed soon. And for the meantime, we have pilot tested this vision screening in several of the schools. As you can see, we train trainers per district, and the trainers would train the kindergarten teacher. We also train the school nurses in each school, and they are the one training the kindergarten teachers. And as Dr. Pauline mentioned, you need to do some intervention and probably give eyeglasses to these kids. No, I mean, for it to be acceptable and for it to be sustainable. But one important key factor here is when we collaborated with Department of Health. It was easy because it's something that could intervene a problem in school. But with the Department of Education, it was a challenge because we don't provide eyeglasses at that level. No, so let me show you a video on the intervention we did in terms of education.
Ito pala katulad ni Marty. Kaya pala natin sinasabi, teacher, bukas na lang susulat. Bukas ko na lang ipapas. Teacher, sabay ko na lang gagawin. Teacher, pagod na ako eh. Tapos yung lumabas yung screening natin, isa pala si Marty sa baby. Talaga ang problema. Kaya ginawa ko, sinubukan ko siya ilipat sa ulo. Sa baratay, kasi malamang siya eh. Tsaka malaki, kaya hindi ko siya may usarap, kaya ko siya sa dito. Kasi siya pa yung natapos at nakapag-check ng mga gawain. Tapos nababasa na niya yung sinusulat.
So with that, it was easier for us to do this pilot testing and implementing this. We're giving out the kit to several schools, and as an example, in Cavite, they screened 600 pupils, around 90% passed, and then so So they're looking at the, yeah, and then around 9% failed, and of the 9% who failed the pass failed the critical line testing, the 45 3/4 had error of refraction, and around 0.8% would have amblyopia. And right now, while waiting for the bill to be passed, we also are coordinating. The DOH is working with the PhilHealth to be able to provide eyeglasses to these children. But of course, the key here right now, as we are implementing it, is that they are placed in the front row of the class to have an immediate intervention and to improve their performance in school. Thank you.
Thank you, Dr. Cobillan. We are now open for questions. Please feel free to type in your questions in the question box. Do we have questions now? Good AM. Good morning. How do you have any feedback on the primary eye care program of DOH? From Dr. Irma Mendoza, former MHO of Bataan Municipal Health Office.
I think it's Leo who may have feedback. So I don't know what's going on.
Yes, the Department of Health, they are working on the primary eye care program. They are in the last few stages of developing guidelines for this, and before it's being rolled out. And I think they will start with the provinces with in the lower quintile of the income group before they move it up for the entire country. Meron pa ba?
Yeah, for me, I noticed this is summertime. It's aside from conjunctivitis, it's also enrollment time, and several schools already have this as part of their program. It's actually a requirement at least the private schools, because I see a lot of this students coming in, and they're required when the first time they enter, and now every year they enter, they're required. However, the vision screening test are these Leia charts commercially available, or is Raspberry need a marketing arm to promote the Leia charts or the better charts that we have?
Okay. Yes, it's true. No, so with Snellen, you could use it probably in older age group. No, but at the start when they're like 5, they're nonverbal. These children, they can't recognize the letters yet. No, it would be good to use the alternative, the appropriate chart. The Philippine Eye Research Institute are producing the kit, no, the vision screening kit. And right now, supposedly when the bill is passed, the government will distribute it to all the kindergarten schools in the country. And for the meantime, we looked at the corporate sponsors. So we're able to give this out to the different schools. But they can certainly coordinate with the Philippine Eye Research Institute on ways how to get these charts.
I think you can order it online, but I think it's cheaper. I think there was a deal because we're third world and it's a research arm. I think it's cheaper to get it from the Philippine Eye Research Institute.
How long do you expect the law to be passed or to be implemented?
Well, if the law is passed for this year, no, it takes around maybe like another 1 to 3 years for the IRR to be drafted and for it to be implemented, and hopefully in the next 2 to 4 years, the PhilHealth will also have their checkup package where they can provide services for outpatient for outpatients, and so that will come hand in hand when we roll this out for the rest of the country. Like what Noel, Dr. Crane, you mentioned, the public schools, they're able to require this before children go to kindergarten, but for the rest of the public school system, they are just screened in school.
Earlier in the lecture of Dr. Santiago, it was mentioned, amblyopia was mentioned. So oftentimes you see patients in our clinic and they say, your son or daughter, you need eyeglasses. And sometimes they feel, my son is too young to wear eyeglasses. Can you introduce the concept of amblyopia and how do we treat that?
Okay, this is how I do it. No? Before, even if the refractive error is very high and is potentially amblyogenic or causing amblyopia, I usually just give them the glasses first. Usually, if you give glasses time to work, you see them again, you will see that their vision improve. No? For those patients now who will have a better eye compared to a non-preferred eye, then those are the patients that I will start amblyopia treatment. So what is amblyopia treatment? The traditional amblyopia treatment is still patching of the better eye or penalizing the better eye with atropine 1% once a week. There are a lot of studies on iPads where you use virtual reality. You give a different type of program for the amblyopic eye and a different type of program for the seeing eye. Those are being studied, and I think Philippine Eye Research Institute is into developing some type of treatment also in the for amblyopia. No, maybe Dr. Kubilyan can expound on that.
Yes, as what Dr. Pauline mentioned, that there are many programs for this where you do the amblyopia treatment through images that they can see on screen. And although the traditional treatment, you treat one eye at a time with patching, so they also treat using stereoscopic vision. And so they are employing now virtual reality. So we are collaborating with the computer department of the UP Manila to develop virtual reality programs that would possibly help in the treatment, so that it will be we can use it for our country without having to buy the program that are produced right now in other countries. And hopefully, Dr. Pauline can work on the clinical trials for this once we have the program in place.
I have other questions online. Besides the screening, are there other programs for the screening of the eye? How about nutrition of the eye from the late?
I think even the just vision screening, it's not really completely off the ground. No, we just have pockets of local LGUs. Maybe some of the pediatric ophthalmologists also go to some localities to. But I think there is really still no national program for screening. No, we're still in the trying to get legislation passed. I'm not sure about nutrition. I don't know anything about that.
With nutrition, the government gives vitamin A supplements. Actually, before, when there were a lot of people with children who were malnourished, and there's really a high level of vitamin A deficiency. At a certain, in the severe group of patients with vitamin A deficiency, we were able to see eye diseases caused by vitamin A deficiency. At the time when I was doing residency, we were able to see those eye redness with some indications for vitamin A deficiency. But right now, actually, the level of vitamin A deficiency is still significant, but not at the level where they can produce eye diseases. But we still have the program on vitamin A supplementation with the government.
On nutrition, I remember before yung bagong lipunan mas ban.
Yes.
Tagal mo na matanda.
Oo nga.
It was eluded by Vice Ganda.
Hindi, but Noel, that the program is really important, nutrition. No? As we go around the different and this is we're talking about the nutrition for the kids. No, so we go around screening kids, no, kindergarten. Their problem is not really their vision. Some of these kids, when you ask them in the interview, they didn't have breakfast for the day. So when you tell them you have a problem seeing the blackboard, that's less of a problem for them. So hopefully the additional the food, breakfast for children they have programs for that, and hopefully there will be more schools with that.
There's another question here. How often do you encounter ethambutol-related visual problems among pediatric patients with primary complex? Is this irreversible if it happened? From Ren to Karasi.
I haven't encountered ethambutol toxicity in my practice, although I've been sent patients for screening for ethambutol toxicity. I think our pulmonologists are a little bit careful. As long as you stay within range of the recommended dosage, 15 to 25 milligram per kilogram, if I'm not mistaken, I haven't seen one. Although we continue to monitor them, I haven't really seen one. Is it reversible for those patients that who've had it? Sometimes it's idiosyncratic, sometimes it can be reversible, sometimes it can be irreversible. So
yeah, I've seen patients with ethambutol toxicity, but most of the patients we see are like what Dr. Santiago said, that we screen patients before giving ethambutol. But when they do have, yes, it's not consistent, but when you withdraw the drug, some recover, but some
don't.
Yeah, I believe we have it more in the adult patients because they have the fixed combinations.
Right,
but in
right.
children, the dosage is according to weight. What are other factors for error of refraction among children? Is it preventable among children with parents who have the error of refraction?
The children with higher risks for developing error of refraction is really children of parents with error of refraction. So there's a genetic component to it. Then you get patients who are premature, who have a higher risk of developing refractive errors. You have patients with craniofacial syndromes who also have a higher risk. Patients with ptosis will have a higher risk. Then that's the nature part. The other part is the nurture part, no? How patients abuse their eyes. No? I think this younger generation, you see 1-year-old on the iPad or the iPhone playing for prolonged periods of time. No? It creates some changes on your ciliary muscle and predisposes them to earlier development of refractive errors. It doesn't happen all the time, but there are more predisposed patients. So those are the things you can control. No? You cannot control genetics, you cannot control nature, but the nurture part you can control. No? So they don't need to use the iPhone before age 2. No? They don't even need to use the iPhone before age 5, but they do use them as babysitters. No? So those are the things you can prevent. No? If you minimize their exposure to gadgets, get them out, get them to the sun, get them to play outside, get them to play outdoors. Prolonged reading, extended hours of reading has actually the same effect. It's not just using the gadgets. I have patients who are not gadget users, but gobbles up reading and reads for maybe the whole day. While waiting in the clinic, he's reading. While eating, they're reading. So those are the things we can modify, behavioral modification, so that we can reduce the contribution of nurture to error of refraction.
There's another question. I think this is Dr. Alex, who is the orbit specialist. Comment is, I hope you would be able to screen for retinoblastoma, because this is mentioned in checking the red orange leaflets earlier. Together with this program, since this is a life-saving thing, if you can pick up, aside from retinoblastoma, how do you pick up, Pauline, this condition in early age? Because we're dealing with patients who are 5.
Alex, I'm with you. No, I am a proponent of universal vision screening, except that's too early for mass application. No? I would rather see all babies first, no? Dilate them in the nursery, then we screen them at 6 months and dilate them and see them inside. see the retina inside. No? But for mass screening, it's going to cripple, I think, the public health system. I don't think we're ready for that. Now, at age 5, if we do pick them up, you will see that they cannot read. So if you do a vision screening at age 5 and they don't read, then you see leukocoria, then you evaluate further, they get referred to the ophthalmologist, then you can pick up retinoblastoma. Someday we will get there, no? Modify the screening to an earlier age because we want to screen them earlier, really. No? But we're not there yet. We will get there. We will work on it eventually once we get this rolled out, and then we have the program continuing. Then the next step is to get to an earlier screening,
Right.
so that we pick up your retinoblastoma patients.
Actually, for mass screening, as we pointed out, it has to be cost effective if you want to include. No? So we are starting with that. So it's the screening for EOR and amblyopia first. And hopefully in the future we can include the others. But right now, the DOH is also working on screening among patients who would go to the center. And hopefully they will, and they are actually including those indicators. The people who screen would be nurses and the medical doctors in the community. So we are working to also to include those the key points that they have to check, so that the patients can be referred to an eye care professional.
Well, for retinoblastoma, it would be a much younger age to pick
Yes.
them up, usually before 2 years of age. And we were taught before that if there's eye deviation and leukocoria, if you can pick it up, then you have to refer the patient.
Actually, for everybody who's listening, no, the way to pick up eye deviation is just alternately cover, uncover, alternate your cover, and then if you see any movement, you refer that patient. That's the easiest way to pick up a deviation, because it can be latent. The eyes can look straight, but once you put a cover, you can pick up a latent deviation, and you will pick up a refixation movement and refer those patients. There is a question here. I think he got offline before he could type in the name. How does prolonged screen time really predispose to EOR? And can you suggest any eye exercise? How does prolonged screen time really predispose to EOR? You will see a lot of these patients with prolonged screen time really with induced higher myopia than your objective refraction, and higher cylinders or astigmatism than your objective refraction. And I ascribe that to changes in the ciliary muscle and the lens. So the ciliary muscle is a muscle for focusing. It creates a anterior posterior change in your lens. Your lens is the one that focuses the image on the retina. If your ciliary muscle is tired, it's your focusing muscle. If it's tired, then there is a sustained tone or accommodative tone, and you have induced myopia and astigmatism. So requiring glasses, sometimes higher than what you get objectively. The other question is relaxation or exercises. The 20-20 rule has been propagated. I think our Philippine Academy of Ophthalmology will post that soon on eye care. It's 20 minutes of screen time. You take 20 seconds off, you look 20 seconds away. 20 feet, you look at 20 feet, then you count 20 seconds, then before you go back to your screen. That's breaking the cycle of sustained focusing or accommodation.
We also recommend that in the workplace, just kids, even in the workplace, you do the 20-20 rule.
20-20-20.
Yeah.
Tatlo yun eh. 20 minutes,
20 minutes,
20
seconds.
feet away, 20 seconds break.
So this break
you look far.
Look far.
yeah, this is more crucial for patients who are in young age developing refractive errors, or would you say refractive error will also happen at the age group when they're employed at 20?
Yes, you get induced myopia. That's why you also get college myopia. We used to see it only in doctors or lawyers, but we're now seeing it in children because of their sustained near work with gadgets and
So that can be an excuse for work.
Actually, it can cause eye strain.
I have to take a break.
You can get induced myopia. Many of our workers in the BPO industry, they lack sleep They are on the computer a lot, and you get also induced
Yes.
myopia and astigmatism.
Pauline, do you believe in this anti-fatigue or eyeglasses, which are supposed to give a little accommodation, to relax accommodation, or is it a fad, or is studies are still not conclusive?
I don't know. I still have yet to read a study that will convince me it works.
Yeah, I think that's difficult to prove. Yeah, the study designed for that to prove
That it decreases
yes.
development of myopia,
Right.
Yes.
or maybe at the most they would just claim that there is decreased asthenopia or eye strain.
There is, if you read about halting myopia progression, there is a school of thought. There's a group of uh, investigators, no, saying that if you use the myopic lenses, presumably they put a little bit of ads in very small amounts, no, to decrease accommodation. There is another school that actually says they decrease it to only an extent so that it follows the curve of the retina.
Yes.
No, para your image is always focused no matter which part of the retina you're using. No? So that is more accepted technology
Yes.
than just the straight out adding of some addition. No? But it's still going to be, I still think it's going to be very difficult to prove. No? I still have to see a good study where it will convince me that it works. And it's a very expensive lens too.
We already answered the prolonged screen time, which is similar to just prolonged reading time. How about dyslexia? Do we have screening in school children for dyslexia?
Kasi yung dyslexia is a little bit different, no? I do get referrals because the patient has been diagnosed with dyslexia. But when they're reading the charts in the clinic, they actually do well, no? So dyslexia is really a diagnosis that is not made by the ophthalmologist, but is made by a developmental pediatrician. No?
Yes.
So your role as ophthalmologist is really just to screen if there is really any other eye problem. We do not diagnose dyslexia. We diagnose eye problems if it's contributory to the difficulty with reading, then you clinch it. It's not dyslexia, it's an eye problem. But dyslexia is a diagnosis by the developmental pediatrician.
That's why also for the vision screening tool we utilize for kindergarten pupils, we use the symbols, and so it's not affected by the learning disability or learning aspect of the person or learning capability of the person. So they just point to the symbol, which corresponds to the symbol pointed by the teacher.
A lot of our questions deals with using the cell phones
Yes.
and the gadgets.
Yeah.
And I think, when the patients come in, before they leave, the mother looks at you, doctor, bawal po yung cellphone, di ba, or gadget. They always have
They
that
always
remark.
ask you to be the one to tell the patient
To tell
that
the
don't
patient.
use the gadgets. Unfortunately, in this day and age, gadgets or the school really uses a lot of e-books, and all of the research are on the computers. No, so I think one is moderation, two is doing the 20-20-20 rule, and don't use it as a babysitter. No, don't use it as a babysitter. And there's a question here about studies causing myopia. I think it's already proven. No? The farmers don't get as much refractive errors. Those out in the sun don't get as much refractive errors. Those who are studying, those who are lawyers, those who are doctors, many more, a more significant number require glasses.
For those interested in, you mentioned about the use of cell phone. Actually, there are several studies on age-related maculopathy induced by the blue light hazard. By the blue light hazard. The blue light has a high energy and short wavelength. So blue light can induce macular age-related macular degeneration. And if you're with your cell phone, there's an app or there's a setting where you can remove the blue light, and that will help reduce the blue light entering your eye. And in fact, in patients we operate for cataract the implant we use have yellow tint to reduce the blue light entering the eye.
We tell our children to go out in the sunlight so they don't get myopia, maybe get cataracts later on. Macular disease.
I want to answer this question. Good day, doctors. How do you feel about ortho-K? Ortho-K is orthokeratology as a mode to address high myopia in kids. No? I feel very strongly against orthokeratology. What is orthokeratology? It's purposely fitting the eye with very tight, rigid gas permeable lens that the kids wear at night. No? So you flatten the eyeball, you flatten the cornea, the kids sleep with the contact lenses, and they wake up, they remove the contact lenses, and then they don't have to wear glasses during the day because you flattened it, and at night it will relax back to its regular size, so you have to put back the contact lens again. First, there's increased risk of infection. Second, there is increased risk of distorting the cornea because I've seen corneas distorted with ortho-K. When you do your refraction, it's an irregular Myers because the cornea has been flattened or has been deformed. No? Just to graphically demonstrate the effect of putting purposely a tight fit contact lens. Imagine you remember the grandmothers of Chinese descent, no? When they used to wrap the feet so that the feet size do not grow. Those feet are actually deformed feet. They can't walk, they can't stand well. No? So this is the things that I am really against by using orthokeratology. Maybe Dr. Cubillan, as a cornea specialist, can discuss also the effect on the cornea.
Well, when you put tight-fitting contact lenses, like in this case, as an example, if you need to refract the patients, sometimes in patients wearing it for several days, you have to wait for at least a month before you can refract them, so that in the hope that during the month the eye would go back to its original shape. And well, I see this also as a problem because when you do this, there's an irregular, there would be the stability of the refraction is not good. So the eyeglasses that you prescribe to the patient, they cannot use it during the time when you are having this intervention done, and then the degree by which it can correct temporarily myopia may not be significant for the current condition of the patient. So in the period where the treatment is being done, they cannot really see well.
So we had a very fruitful afternoon. So a lot of the questions were about children, glasses, gadgets, because children, it's really an emotional issue for parents. So let's learn that from this session that we just want to pick up. Do you have a need for glasses? If you need glasses, then we will give you eyeglasses. It's not a disease. The patient will become a normal person after that. So we would like to hear from all of you. Kindly answer the survey you will be receiving at the end of this session. We can assess and improve our webinar. You can also receive your certificate by answering the survey. Invite your colleagues to join the continuing webinar series, like our Facebook page, and subscribe to our mailing list for schedule updates. You can also email us at the UPWebinars 2018@gmail.com for any inquiries. Once again, we would like to thank Manila Doctors Hospital for sponsoring this webinar. On behalf of UP College of Medicine 1993, the UP Medical Alumni Society, we'd also like to thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine, and Medical Informatics Unit, DOST, ASTI, and of course, Ms. Cha or Halo of AHIN. This is Dr. Carino together with Dr. Santiago and Dr. Cubillan closing this session. We hope you have learned a lot from today's webinar. Join us again next Wednesday, May 16, with Dr. Michael. May 17,
tomorrow.
May 17, Dr. Michael Joseph F. Agbayani. is for our webinar on World Hypertension Day. Know your numbers. Thank you and see you again tomorrow.